name is Florence. I'm a French teacher. I'm 46 years old. 2 years ago, I was about to start professional training to become a teacher in the secondary education in England. And after my induction week at the school, I was diagnosed with myeloma.
Myeloma is a blood cancer which originates in the bone marrow. We don't know exactly what causes myeloma, but plasma cells in the bone marrow become cancerous and release a large amount of an antibody called a paraprotein. Unlike many cancers, myeloma doesn't exist as a lump or a tumour. Most of the problems related to multiple myeloma come from the presence in the body of these abnormal myeloma cells and the paraproteins. Myeloma is also what's known as a relapsing and remitting cancer. This means that even after a period of successful treatment, when a patient experiences a remission, their myeloma will always return. Myeloma is also an evolving cancer, which means that it becomes resistant to treatment, and when a patient relapses, they will need a different type of treatment to bring their myeloma under control.
Mainly back pain. I was in so much pain, sometimes I could scream. And I was going to that training thinking, how on earth am I going to go to do it for a year, because I feel so tired all the time. I have a little girl, so she's 6 years old, and she was obviously 2 years younger. 2 years ago she was 4, so she needed a lot of attention. But I had to carry on with my tasks of being a mother and take care of her and moving the best I could, but everything was a struggle, everything. The GP said, well, I think we're gonna have an X-ray done, and the X-ray showed that I had a collapsed bone in my back for no reason, because I didn't fall down, I didn't do anything strenuous. I mean, nothing explained this broken bone. So that's when things got a bit more serious.
Myeloma patients experience some of the longest delays in diagnosis for all cancer patients at 163 days. This is primarily because of the length of time between a patient first visiting their GP with symptoms and a referral to a hospital for their diagnosis to be confirmed. Actually, over 50% of myeloma patients visit their GP more than 3 times before they are referred to a hospital.
My name's Joanna Sheldon, and I'm a consultant clinical scientist in immunology here at St George's Hospital, and I'm part of South West London Pathology Services. And my involvement in this case was I was actually the person reporting the serum protein electrophoresis on this patient when we had a sample back in July a couple of years ago. The samples were sent to us by the patient's GP, and the tests requested were to measure the protein, some of the proteins in the serum called the immunoglobulins, and people may also know those as the antibodies, so measuring the antibody concentrations and looking at the pattern of proteins that we see in the patient's serum and urine.
We're a protein reference unit, so we see a wide spectrum of cases, often referred from across the country, but locally we see abnormalities on traces, a few a day. That's not to say that all of those patients have myeloma, because some of these abnormalities can be secondary to infection or inflammation. They're just part of the immune response responding or fighting off something.
The antibodies are proteins made by the body. They're made by cells called B cells or B lymphocytes. And we have billions of B lymphocytes, each one making a little bit of antibody directed against one of the many millions of things that we all encounter every day. Because the antibodies are made of proteins that are made of amino acids, every protein will have a slightly different charge. And we can separate all the proteins in the blood based on their charge by a technique called protein electrophoresis. And here's a very typical protein electrophoresis, and the antibodies run down here in the gamma region. Now if we spread that gamma out, long way, very widespread, we can see that it's made up of lots of tiny little peaks of antibody, and each peak is the antibody product of one B cell or one clone of B cells. And don't forget, we've got billions of B cells, millions to billions of B cells. So each one of these little peaks represents the product of one B cell. But B cells, to make antibodies, go through lots and lots of different processes, and there are lots of places where a mistake can happen and that B cell can lose control. And if that happens, instead of having this nice polyclonal response, you can end up with one B cell producing lots of antibody, because that one B cell is multiplying into a clone of B cells or even a B cell tumour. And this is what we would call a paraprotein or a monoclonal protein or a monoclonal antibody that is the product of a B cell clone associated with a B cell tumour. And in this patient, when we looked at the serum protein electrophoresis, we saw this big paraprotein band, and that was the very first thing that alerted us to this being a significant finding, and then the consequent tests and communications with the GP and with Dr. Willis.
Part of investigating patients with myeloma is to look at their urine, and we're looking for a particular abnormal protein called Bence-Jones protein. To do this, we take the urines and then we concentrate them, and that allows us to make the method even more sensitive and try and pick up the smallest amounts possible, the idea being to catch the disease as soon as possible, as early as possible, so that the patient has a better chance of responding to treatment. So the results from this test are how we come up with the terminology that some myeloma patients might see on their notes. When we talk about them having a paraprotein and we say it's, for instance, an IgG kappa paraprotein, that information, the IgG kappa, is found out from this test. When we talk about a patient having an IgG kappa paraprotein, what that is actually telling us is what the malignant cells are making. So the myeloma cells that are in the patient's bone marrow churn out loads of abnormal protein, and that's the paraprotein that we're identifying here. No one lab test on its own gives you the diagnosis. Some of the immunology tests, but other markers that are measured in, for instance, biochemistry, are also relevant to show what's going on with the patient on a more global level. And then all of those tests together are interpreted by the clinician, who may ask for further testing, the imaging and invasive procedures that might need to be done. And all of that put together is how you arrive at the diagnosis of myeloma.
The patient's sample came to us on the 18th of July, and we ran the samples the same day. We found the abnormality, and we were able to phone the GP that evening and speak with Dr. Willis. And Florence was actually seen in Dr. Willis's clinic on the Thursday. So from the time we got the sample to the patient actually being seen by the haematologist was really just a couple of days, which is very good for the patient. It means that the patient is going to be further investigated and diagnosis made and treatment made promptly.
So I'm Fenella Willis. I'm a consultant haematologist, and Florence is one of my patients with myeloma. Very quickly we decided what she needed to do in terms of investigations. I explained that she needed extensive imaging to look at her whole skeleton. So we did what we call a low-dose CT to look at the skeleton in more detail, and a detailed MRI scan, particularly of her spine and pelvis. She needed a bone marrow biopsy so that we could confirm that she had the myeloma cancer, because myeloma cells are normally found in the bone marrow, and then specific blood tests to confirm that she had what we call the end organ damage related to myeloma, so anemia, high blood calcium, and whether she had any renal impairment. So particularly with Florence's back, she had several vertebra in her back that had collapsed as a result of weaknesses in those bones. And when you looked at her CT scan, you could see in the pelvis and in the back that there were holes within the bones, which were areas where the myeloma had caused damage to her bones. The x-rays don't give you a diagnosis, they give you a suspicion of that cancer, but you need histology to confirm that. So the bone marrow biopsy was the way that we confirmed that diagnosis. And to do a bone marrow biopsy requires the patient has a procedure under a local anaesthetic. We take the sample from the pelvis. So usually there's two parts to it. There's an aspirate, which is the fluid bit from the bone marrow, and then a trephine, which is a fragment of the bone which is taken. After we've diagnosed the patient with myeloma, we will do further specific genetic tests to look at abnormalities with the chromosomes that we know are associated with differences in the risk of that disease.
Fenella has been fantastic. She's been fantastic. When I was finally referred to her, I felt, it's funny to say because you should be scared when you have this diagnosis. I was scared, but at the same time I was relieved because I knew that I was in safe hands, that I was in hands of professionals who knew what they were doing. We had excellent reputation, and meeting up with her was very, very reassuring because she felt like very approachable, very human, caring for people with a high empathy for patients. And I thought that's exactly what I need. I need a sort of cocoon around me to be able to get through this and to keep my spirits high. And she helped with that.
The prognosis in myeloma cases can vary quite enormously. We know currently patients with myeloma, we cannot cure their disease, but more and more patients are living with their disease for many years. So in many ways it's more like a chronic illness rather than a short-term acute illness. Patients can sometimes live for 10 years and more with their disease. I suppose the importance of that is if you're living with a disease for many years is focusing not only on treating that disease but also making sure people have good quality of life. So making sure any treatment pathway focuses on the two things at the same time. At the beginning of treatment there were two areas that we had to address. So initially her problem with bone disease, pain and management of her spinal disease was very important at the outset. To manage her bone disease and pain, she had involvement from the palliative care team in terms of optimising her pain control. She was reviewed by a specialist spinal orthopaedic team who recommended that she had a brace and also that she went on to have kyphoplasty at multiple levels in her spine to try and help stabilise her spine and reduce her pain. And she was started on treatments with bisphosphonates to strengthen her bones. For treatment, we offered her an intensive pathway because she was a young patient, and therefore we always aim to get the best response to treatment with the first line of therapy. Because we know long term that the best outcome is usually with the first line of therapy. So she was offered a clinical trial. She was offered that or treatment off the clinical trial, but she opted to go on to a clinical trial. So she is in the sort of last 6 months of that trial. So she comes up to our haematology daycare unit for her treatment, which is a type of proteasome inhibitor treatment as a drip once a week.
If you had asked me the question, how are you going to feel like in 2 years' time, I would never have thought that I would be so full of beans and you know, wanting to do things, experience new things. I live my life to the fullest, in fact. You know, that's what myeloma brought me as well. Living with myeloma is scary because you never know what's going to happen to you. But I feel supported. That's the good thing. I know that living with myeloma is not that bad if you know that a team of competent doctors are behind you and will be able to help you out whenever it's coming back.